So my research presentation is on an article published by the Journal of Personalized Medicine called "The Impact of Marijuana on Antidepressant Treatment in Adolescents." So the official title adds on clinical and pharmacological considerations, but I cut it out of the intro for clarity reasons. And as I said before, it's published by the Journal of Personalized Medicine. So unfortunately, the Journal of Personalized Medicine just barely meets the 5 impact factor criteria. However, with Dr. G's approval, I was able to do research on this article. And a little history on personalized medicine. It's essentially just an individualized treatment approach, which uses a patient's medical history and genetic components to create the best form of treatment and diagnosis for each patient. And this is used to prevent, diagnose, and treat ailments, but there is a huge emphasis on examining one's genes to choose treatment and medication. So this research article was published by Samuel E. Vaughan, Jeffrey R. Strawn, Ethan A. Powlett, Mayer Sarangar, and Laura B. Ramsey. It references 65 different research studies on medications ranging from anti-epileptic medications, antidepressant, and cannabis effects. And it was published in June 29th, 2021, so pretty recent. All right. So in terms of marijuana and antidepressant interactions, there's an enormous knowledge gap because marijuana is still a Schedule I drug. So marijuana status as a Schedule I drug bars it from a lot of research privileges because every research article involving marijuana must receive DEA approval. And in most circumstances, this approval is only for medicinal uses, and in most cases for antidepressant users, marijuana is used recreationally. And even through the process of receiving approval from the DEA, it's very time consuming, it's expensive, and increased security measures are needed to do testing. Overall, just kind of a nightmare to research marijuana. So as a result, this is one of the first study on SSRI and marijuana interactions in adolescents. And as a result, there are very few, little to none, research articles on antidepressant and cannabis interactions. And this is really just doing a disservice to people with depression or other forms of mental illness, because people with depression are more likely to use cannabis, especially, even in the youth. And given that this is applied to an adolescent population, theoretically, it's important. And just in general, given recent state legalization of marijuana, it differs from state to state, obviously, but there's been an increased use of cannabis in adolescents. 6% of 12th graders smoke every day, almost 5% of 10th graders, and 1.3% of 8th graders smoke every day. And when compared to studies in 2018, there has been an 85% increase of marijuana use in the 8th grade population and a 40% increase in the 10th and 12th grade populations. So marijuana is definitely on the rise in America, and people with depression are more likely to use it because their brains are more prone to stress and cannot handle stress in the same way a non-stressed brain can. So they seek relief through marijuana. So these are the research goals that the article posted. So it's to describe the impact of marijuana on SSRI treatment in children and adolescents, to characterize and examine the effect of marijuana on enzymes that metabolize SSRIs. And the enzymes that we look at in particular in this study are CYP2D6 and CYP2C19, with extra emphasis on CYP2C19. And these enzymes are chosen because they're both used to metabolize marijuana and certain SSRI medication. And then finally, the third goal is to examine the frequency of adverse events reported when SSRIs and cannabinoids are used together. And by adverse effects, it means side effects. So here's a little bit more background on the enzymes I was talking about earlier. This is a bit confusing, especially for someone who isn't very adept in biology. But CYP2D6 and CYP2C19 are genes that encode enzyme proteins. And the enzyme proteins that they encode are cytochrome P450-2D6 and cytochrome P450-2C19 respectively. These two cytochromes are a part of a superfamily of enzymes called cytochromes 450s. They're essentially responsible for regulating cellular metabolism and homeostasis, but in this circumstance, they're used to detoxify xenobiotics, which are chemical drugs. To make matters even more confusing, cytochrome P450-2D6 and cytochrome P450-2C19. The enzymes are also colloquially referred to as CYP2D6 and CYP2DC19, which is also used to refer to the genes. In order to differentiate, I put genes after each enzyme if I'm talking about the genes specifically. And like I said, the reason why we focus on these enzymes is because most antidepressants are metabolized by them. And at the same time, marijuana is also metabolized by these enzymes. So CYP2D6 is metabolizes Prozac, Luvox, and Paxil, and CYP2C19 metabolizes Celexa, Zoloft, and Lexapro. In this study specifically, there is more of a focus on CYP2C19 because it was predicted that it would have more interactions with marijuana based on previous in vitro and in vivo research articles. So this hypothesis was formulated based off of in vitro and in vivo research on cannabis and antidepressants, but separately. The only type of research that we were able to reference in terms of interactions was research that referred to anti-epileptic medication, because a lot of anti-epileptic medication is synthesized by CYP2C19, which is the same enzyme that metabolizes certain antidepressants and marijuana. And this was done because, as I said before, this is the first research article on interactions between SSRIs and antidepressants. So we only had anti-epileptic studies to refer to. And the hypothesis is as stated. CBD was predicted to induce strong drug interactions with CYP2C19 and moderate interactions with CYP2D6. So for that reason, there's more of a focus on CYP2C19. However, THC, taken orally or inhaled, was not predicted to induce drug interactions with CYP2C19 or CYP2D6. CBD also inhibits CYP2C19 in vivo, and taken together, these data analyses suggest that medications with a CYP2C19 dependent metabolism are likely to be susceptible to drug interactions with cannabinoids. So that's basically just their reasoning as to why they focused on the enzyme CYP2C19 specifically over CYP2D6. So there were 3 different forms of methodology used to find the research findings for this article, both non-clinical and clinical. However, because there are such restrictions on marijuana as a Schedule I drug, sorry, I lost my train of thought. Because there are restrictions of marijuana, because it's Schedule I drug, they rely more on non-clinical forms of observation because clinical forms of observation require a lot of security measures, or they're just not approved outright. And in order to simulate these predictions, the researchers used type of medical software called MW-Pharm, which is developed by MetaWare, a company in the Czech Republic. Pretty cool. And it's a pharmacokinetic modeling program that enables users to estimate a patient's biological reactions to a medication based off of their genes and medication history, age, body size, and sex. And through using this data, it creates a timeline of the medication plasma concentrations for each patient. So that's pretty cool. And in this study, it is used to estimate Zoloft and Lexapro plasma concentration levels when used intravenously with marijuana. This software is used to show this general study and in a very specific sense for a case study for a 15-year-old that we will talk about later. And because it's a simulated technological research finding, it's a non-clinical finding or not finding, method of research. So this is the case study I was talking about earlier. Unfortunately, we only have one, which further shows the restrictions of having marijuana as a Schedule I drug. So this patient was 15, a female. She had generalized anxiety disorder, which was defined by panic attacks, which subsequent to moderate major depressive disorder. She's a normal metabolizer, and one's metabolizing status is based off of one's genes. And what I mean by metabolizer or the metabolizer status, it basically just means how well your body metabolizes medication. So it ranges from poor metabolizer to ultra rapid metabolizer, but this patient falls right in the middle at normal metabolizer, which makes her a good person to reference. So this patient started on 5 milligrams of Lexapro every day, which was then gradually increased to 20 milligrams over a 2-year period. For the MW-Pharm graphic I'm going to show, it only shows her journey from 10 milligrams to 20 milligrams because she was only on 5 milligrams for a few months. After she confessed that she was consuming marijuana in edible form during her Lexapro treatment, and as a result, her antidepressant side effects worsened. And once again, this research article has to rely on other research, but at the same time, it's not 100% accurate because there's so little research on marijuana. So thus, this article and the researchers use data mining to try and formulate a hypothesis. Data mining isn't specific to a medicinal setting, but in this context, it means extracting individual patient information from a large database to gauge and better understand medication interactions and effects. And in this circumstance, they use the database of the Food and Drug Administration, which is huge. There were roughly 15 million patient reports that were filed through a technological program through data mining. But once again, it created interactions in 3 different cohorts, one being CYP, C219 metabolized medications that could either be SSRIs or anti-epileptics, as I mentioned earlier, cannabinoids, THC, CBD, or combinations of the two. For the combinations, it's almost exclusively anti-epileptic and marijuana medications because, once again, there are very little studies on SSRI and marijuana interactions. So now we're going to look at the data from this methodology. So this is the program that was used. This graphic was made through NW Farm, which was the program I mentioned earlier. Once again, this is a simulated graphic. It is not based off of one's personal experiences. So these 2 graphs are comparing Lexapro concentration and Zoloft concentration, respectively, when marijuana is introduced and when it is not. So if you look closely, Lexapro treatment was initiated at 10 milligrams daily and was increased to 20 milligrams at week 4. For the Zoloft, it was initiated at 50 milligrams daily and every week it increased by 50 milligrams until it reached 200 milligrams of Zoloft, which I believe is the max dose. And throughout this process, 5 to 15 milligrams of CBD or THC were simulated to be administered, with the dosage of the cannabinoids increasing as the antidepressant dosage increases. And as you can see, the green lines represent medication interactions with marijuana, and the red lines just represent normal medication interactions with the body, so without marijuana. And when marijuana and these antidepressants are administered together, the marijuana subsequently increases the concentration of these antidepressants, more so for Lexapro, but also for Zoloft. So this is the case study I was talking about earlier. It's also used NW Farm. So this is essentially mapping out the case study patients' Lexapro concentration levels as she, through time, and then as she administered marijuana. So you can see at around the 15-month mark, the patient began to administer THC and CBD orally. And the green line represents the plasma concentrations. The bars on the top represent the Lexapro medications increasing. And the black line represents the CGI score. And the CGI stands for Clinical Global Impression Scale of Severity of Illness. So the more mentally ill someone is, the higher their CGI score will be. So as you can see at the beginning of the study, before the patient had gotten acclimated to the SSRI, her CGI score was high. However, at around the 8-month mark, her CGI score decreases incredibly so. But at the 15-month mark, once she begins to take marijuana and Lexapro together, her CGI score slowly and gradually increases until it peaks at 6, and then stops at 4 when she discontinues her marijuana intake. So what this essentially means is, because marijuana increases the concentration of Lexapro and Zoloft in its users, it also increases the side effects of Lexapro and Zoloft in its users. So some of these side effects of these medications include fatigue, nausea, dizziness, weight gain, cough, flu, agitation, insomnia, suicidality, basically everything under the sun. And these side effects are so bad that they're overruling, or at least in this case, they're overruling it's worse than being depressed without treatment. But once again, that's just one case study, and you can't apply one person's experiences to everyone's. And then this is the FDA data mine that I was mentioning earlier. So these are also some of the side effects I was listing. The blue to red scale at the top is the side effect prevalence. So the more red a dot is, the more prevalent it is with the medication. And as I mentioned before, the CBD and CYP 2C19 interactions, those figures were taken exclusively from anti-epileptic and cannabinoid interaction studies. And as you can see, there's an elevated risk of antidepressant side effects when it is taken with marijuana, especially in the fatigue, diarrhea, dizziness, and cough regard, which makes sense considering that weed makes you tired and gives you a sore throat from smoking. Oh, I did not mean to do that. Very sorry. And then what does all this mean? So, as I had mentioned in the previous slides, it is likely that CBD and or THC increases the concentration of sertraline and escitalopram, and sertraline and escitalopram are Zoloft and Lexapro exclusively, respectively, sorry. And this increased concentration most likely results in more severe antidepressant side effects. Those side effects range from mild things such as fatigue and whatever, and it ranges to more serious side effects such as suicidality. Thus, decreasing marijuana use will likely decrease sertraline and escitalopram concentration, which would thus decrease the efficacy of such drugs. So if the marijuana intake stops suddenly when sertraline and escitalopram medication intake continues, it's likely that the effectiveness of the medication will decrease. And as a result, clinicians should always inquire their patients on their marijuana use before they prescribe CYP 2C19 medications, in this case, just SSRI medications, simply to gauge dosage. Because if someone is smoking marijuana, they would probably need a lesser dosage because it increases the effects. So there are many limitations to this research, mostly because marijuana remains a Schedule I drug. The FDA and the DEA are the two administrations which determine the schedules of drugs. And as it stands, marijuana is culturally more accepted through state legalization. However, we still have a long way to go before it is legalized everywhere, and it's unlikely that it will be ever federally legalized. And once again, this research is limited not only to, it's literally on just 2 SSRI medications. So it doesn't do a lot of research on SSRI medications that interact with CYP2D6, and those medications include Prozac and Luvox, I believe. There are many chemical components in marijuana that influence one's behavior. However, this research study only focuses on the cannabinoids, CBD and THC, and just cannabinoids in general. Once again, I mentioned one's metabolizer status can affect the potency and effects of such drugs. So if someone has an ultra rapid metabolizing body, then their body will be more responsive to medication, whereas someone that is slowly metabolizing medication, they are more likely to experience side effects and more likely to discontinue antidepressant medication. And the effects of cannabinoids differ greatly depending on the route of administration. So whether it's eaten or smoked or consumed in other circumstances, the potency of the cannabinoids changes. And again, some strains of marijuana are more potent than another. So it's hard to gauge the effects because marijuana is such a versatile and wide-ranging drug in terms of experience. We only look at one case study because that's all that we had available. And one case study cannot represent every adolescent's experience. And once again, this research study is also only in adolescent populations, and there are many people who smoke weed and take such antidepressants that are not adolescents. And the FDA database is the interactions between CYP2C19 and cannabinoid medications are based solely or mostly off of anti-epileptic interactions with marijuana. So the biggest limitation is not being able to test on an actual population and mostly relying on simulated and non-clinical forms of observation. But once again, they had to rely on such research methods because of marijuana's status as a Schedule I drug. Yeah, so once again, there's little to no research on antidepressant and marijuana interactions because of the status. Legal access is increasing and stigma around marijuana is decreasing. So there's speculation that it's on its way out of being a Schedule I drug. However, there's no guarantee that this will happen anytime soon because state by state legalization of weed definitely slows down the research process and legality of marijuana. However, a fast solution to this would be to enact federal marijuana legalization, but based off of the current administration, it is very unlikely that that will happen. And even the more progressive leadership in the DEA and FDA that Biden appointed, they mostly support medical marijuana use, but they do not support recreational marijuana use, which does not spell good things for the legalization of marijuana. And research must be conducted on an actual population in order to produce conclusive data. Another limitation I didn't mention was this study only focuses on certain forms of SSRIs, so it completely discounts other antidepressant medications with weed. And the antidepressant classifications include SNRIs, which are serotonin and norepinephrine reuptake inhibitors, NDRIs, which are norepinephrine and dopamine inhibitors. However, that is only for Wellbutrin. MAOIs, which are basically there are a lot of antidepressants, and this research is only specified to SSRIs and not even all of them, just Zoloft and Lexapro. So in order to provide conclusive data and treatment for people who are using antidepressants and marijuana together, we must perform more research on real populations, and this can only be done through the legalization of marijuana nationwide. And that concludes my presentation. Oh, also, this is a brain on marijuana. Pretty cool. Thanks for watching.